A bowel obstruction is just as it sounds. The GI tract is one long continuous tube, and the small bowel in the normal setting is very free to flop about in the abdomen and isn't really fixed except for a couple places. But either with hernias, which are little breakdowns in the musculature of the abdominal wall or a hole, or adhesions from previous abdominal surgeries, you can get some areas of the small intestine which may be 20 or 30 feet long, but you may have a small area that's trapped or kinked, either due to adhesions from previous surgery or being stuck in a hernia. When that happens, obviously things don't pass through normally. And so depending on where you're obstructed, you may get very bloated and have crampy abdominal pains. It can be almost anywhere in the abdomen, usually a lot of nausea and vomiting. When I explain the anatomy of the small bowel, it's not unlike a garden hose. Just as you know, as you're pulling a hose off of a reel or around a corner, you can have unusual little kinkings and twistings, and the small bowel is very similar to that. When you get those kinks, a lot of times you probably note when you take the pressure off, things will kind of untwist and open back up, and the bowel's no different. But many times those kinks, the things are tethered in a way that it's not until we get in there to surgically lyse those adhesions or scar tissue that the bowel can then be relieved and open up. Most of the time it can be managed non-operatively. You know, we will decompress things with a tube that people don't like very much, but it does a nice job and it's better than surgery. And then we'll give it a few days to try to relax and untwist or unkink as long as the patient remains stable. There are times where we know it's not going to relieve. For instance, if they have an incarcerated hernia, that's got to be fixed immediately. And we'll take that to surgery day or night, whenever it's needed and they present.